So it's 8 p.m. We can start the webinars. First of all, I would like to thank all of you to be so many to attend this second edition of the NIPLUS webinars. I also would like to thank Dr. Philippe Van Overschelde to be our special guest today. Dr. Philippe Van Overschelde is a hip and knee surgeon practicing in Ghent in Belgium. Dr. Van Overschelde is one of our most well-known users in Europe. He has performed more than 700 NIPLUS surgeries with the medial pivots, the implant from MicroPort. He is passionate about technologies, but also about clinical data collections. And as a co-founder of the MoveUp data platform, he will present the different data related to his NIPLUS cases. So thank you, Dr. Van Overschelde, to be here with us today. For the organization of the webinar, I will start with a quick introduction about our company, but also our project. Then I will let the floor to Dr. Philippe Van Overschelde to share his experience. And at the end, we will also have a Q&A session. So if you have any question, there is a channel called Q&A that you can see at the bottom of your screen. So if you have any questions, please type them in the chat and we will answer to them at the end of the session. Thank you. So first of all, what is Pixie Medical? Pixie Medical is a French and innovative company focusing in the use of augmented reality for total knee replacement. Since we have been founded in 2018, we already have performed more than 10,000 surgeries across the world because we are already distributing our product in more than 20 countries. Since we have been founded, we are just keep on expanding our size. We reached the 51 employees a few days ago. And since last year, we also opened our first subsidiary in the US with also an American sales team. As I told you, we are a French company. So our main focus when we launched the product was the French market and also the European market. Here on the map, on the left side, you can see the different countries where our product is already distributed. And then on the right side, you can see our out of US sales team, which is composed, first of all, by our sales director, Mr. Anthony Seglia. We are also composed by 2 clinical sales managers. So my colleague, Elliot Stantina, in charge of the European countries, and myself, Liz Morse, in charge of the rest of the world market. Last but not least, we also have our product manager, Arvo Meyer, in charge of the development of the new version of our system. So I would like to talk about why are we using augmented reality for total knee replacement and what is it exactly. So the augmented reality is a technology that allows to overlay some digital elements into the field of view of the surgeons or the users. In our cases, we are using some smart glasses and we are projecting the different values that are interesting for the surgeons for total knee replacement. So with augmented reality, we were able to create a real GPS for the surgeons. With this technology, you're able to have a guidance in real time and also stay focused on the knee because you can combine the perception with the digital information and what you're really seeing. With our product, we were able to achieve an accuracy which is comparable to the different robotic systems already on the market without the use of any bulky equipment because everything fits in a headset with the augmented reality glasses and a small tray of instruments, which is 20 centimeters over 20 centimeters. Our system is also a universal platform, so you can use it with any implants. Here on this slide, you can see more in details how our solution look like in theaters, so in the operating room. So as you can see, we have some instruments which have different markers. And with our glasses that you can see on the head of the surgeons, we're able to track the instruments in real time and have a precision of less than 1 degree and less than 1 millimeters. The perception that you can see here, it's exactly what the surgeon is seeing in the glasses. And to control the software, the surgeon can either use an accelerometer or a voice control. So with Knee+, you can see the invisible and cut with confidence. And I will finish my quick presentation about why so many surgeons are enthusiastic about using Knee+ neck site in their practice. First of all, because it's patient-oriented. We know that each patient is unique, and that is why every Knee+ surgery is unique. We're going to take some landmarks during the operation according to the anatomy of our patient. I already told you, but with Knee+, we can give the surgeon the accuracy and the control with precision comparable to a different robotic system. Our solution is also a disposable free solution, so you don't need to throw anything away after the surgery. You can reuse everything, you just need to sterilize them in an autoclave. And for the footprint, we have a 0 footprint. So that's it for my little presentation. Now I will let Dr. Van Overschelde share his experience. Just as a quick reminder, if you have any questions, please type them in the chat and we will have time at the end of the session. Thank you.
Good evening, everyone. My name is Philippe Van Overschelde. I work in Ghent, Belgium, and we're going to talk tonight about the medial pivot total knee arthroplasty augmented with the augmented reality. First of all, what makes a happy knee? Well, it's the restoration of the optimal alignment and balance in extension and flexion with the correct implant type and size in the correct patient. If you have all these 5 determinants, you can achieve a happy knee. Let's first talk about the medial pivot total knee arthroplasty. We know from studies, and that's more than 20 years ago, that the medial and the lateral compartment, they behave differently. The medial compartment is stable, whereas the lateral compartment allows a lot of motion in the AP direction. And that varies from individual to individual. So our native knee is a medial pivot knee. So ideally, our total knee arthroplasty should also medial pivoting. The true medial pivot knee is the combination of a single radius femoral component in the sagittal and frontal plane, together with the typical medial pivot insert. That system that we've been using for now 27 years is for us the true medial pivot knee. What is the true medial pivot knee? It's a knee that provides stability. And when we look to our data in our department, comparing the medial pivot knee to the PS knee, you see that our composite index, which is called the move-up index, increases by 68 or 58% in certain cohorts with a medial pivot knee, where it only increases 46% for PS knee. So patients with the medial pivot knee are more satisfied compared to patients with a posterior stabilized knee, as you can see here with the Knee Society satisfaction scoring. Pixie, as Lisa said, is a solution for every knee implant, for every alignment philosophy, and we want, of course, a solution for every patient. That patient has a valgus knee on one side and a varus knee on the other side. Well, the Pixie system can provide the solution for that patient. My total knee arthroplasty balancing rules for now more than 20 years is to reproduce the natural situation, which is tighter medially than laterally and tighter in extension and flexion. There is no release of the superficial MCL, and we allow for individual variability, especially on the lateral side. You see here a graph representing 10 living subjects after implantation of a medial pivot knee. That's the lateral compartment. See, that's not a steady line. There is a lot of variability between individuals. That has been my alignment journey in 20 years' time. I started in 2005 with the mechanically aligned medial pivot implant. In 2018, I visited Stephen Howell and went to unrestricted kinematic alignment. I did that, I fine-tuned it, and nowadays we're using a more functional alignment together with the Pixie system. I will come back on that later on. Why I'm do not recommend to use unrestricted kinematic alignment just with instruments and no control, because it's not safe for any phenotype. Here you see a patient that I operated in 2018. At that time, I didn't have a full leg X-rays. And that patient, 6 weeks after surgery, went into progressive valgus. And that's one of the pitfalls of unrestricted kinematic alignment without using assistive technology. You can end up in excessive femoral valgus or even femoral varus. And a femoral valgus and a medial pivot knee, they don't go together. And I had inferior clinical results in some cases. That's why I wanted technology in my practice. Especially for the femur, it's very difficult to control 1, 2, 3 degrees of valgus or varus with only your eyes and metal instruments. On the tibia, it's a bit more easy, but I do recommend to use assistive technologies if you want to perform personalized alignment. I give you a small intro to what's the difference between virtual reality and augmented reality. I think there's a little bit of music here, so you will remember the virtual reality creates a completely simulated environment. So when you remove the glasses, you're back to reality. With augmented reality, it's different. It enhances the real world with digital information. And I'll show you how I do this in my practice. As Lisa said, it's really simple. You have just one single tray with sterile QR codes, which is 20 by 20 centimeters, and you need smart glasses and a camera. It's fast and reliable. You don't have disposables. The sequence is you scan the QR codes, you approve the settings, you select the surgery site, and you can start the case. I typically start with the femur. So I fix my femoral QR code on the distal femoral surface. I acquire the hip center. I set my angles and resection levels. I make the cut and I verify my cut. Same is true for the tibia. I fix the tibial QR code. I acquire the tibial axis, set angles and resection levels, make the cut and verify the cut. And I will show you, I measured today in my operating theater how many minutes I need to complete all those steps. I will present you a case of last week because it's a valgus case. And many people say, well, valgus knees and medial pivot knee, they don't go together. That's a lady with a valgus of 9 degrees with some MCL stretch, as you can see. And her pre-op move-up index is 38.4. Just for your information, the maximum value of the move-up index is 100. If you can double the score, you have a good candidate for surgery. So it's a 79-year-old lady with a BMI of 33.9, and it's the right knee. As I said, the first step is to place the femoral QR code. I use a headed pin as a first pin, and the first pin is the most important. You need to center it on the distal aspect of the femur. And once it's fixed with the one pin, you add 2 headless pins. Depending on the anatomy, you will have some varus valgus or even rotation. Well, the system allows to have 10 degrees of tolerance in order to acquire the mechanical axis of the femur. The acquisition of the hip center typically was 10 points. Now with the next side system, it's becoming 5 points. So it's even faster. It's very smooth, and we also have to acquire the femoral surfaces, as I will do now. I start with the lateral surface. I take 3 points, which are the most distal points on my femoral aspect, and I take 3 points on the medial compartment. Up till now, when I start using the Pixie, till this moment, it's 1 minute, 31 seconds. After that, we have to fix the other device to the QR code, and we are going to set the angles and the resection level. For this particular case, because that lady had some hyperextension, it was not a real tight knee, it was more a lax knee, I set my values, as you can see here, 0 degree valgus, 0 degree flexion, a 7 millimeter resection of the medial compartment, and only 2 millimeter resection of the lateral compartment because of the excessive valgus. The next step is to cut. And while cutting the first surface, my nurse is measuring every piece of bone I resect. So this step in the surgery is 36 seconds. After that, we reposition it and we check our angles and resection levels. So we allow a 1 millimeter or 1 degree difference. So that's a tolerance. In this case, we had 1 degree valgus on the distal femur and 0 degree flexion with a resection of 2 millimeters lateral and 7 millimeters medial. The next step is placement of the tibial QR code. I like to remove the spines, as you can see, because then I have a flat surface. I mark the rotation of the tibia, and then I position my head on top of the tibia. So I have a good view on rotation and a good positioning of this tibial QR code. The first pin is the headed pin. It's the most important one. And then you put 2 headless pins. I like to use the small cutting block. And the next step is to acquire the axis of the tibia and acquiring the tibial surfaces, as you will see here. First, we acquire the lateral malleolus. In the next step, we acquire the medial malleolus. All these steps together is 1 minute 44 seconds. Then I set my angles and resection levels. In this patient, normally I would cut 8 millimeters because it's a valgus case with a stretched out medial collateral ligament. I've put my values 7 millimeters medial, 6 millimeters lateral to obtain a 0 degree angle and 7 degree slope in that patient. That's how we do. We turn the knobs to set to 0 degree. And I have this jig, which I let down, and then I see my 7 millimeters on the medial compartment. Sawing is done via a small block. I like to use it because there is no conflict with the patellar tendon. Originally, when we started in 2021, we had the large block, but the large block sometimes had a conflict with the patellar tendon and pushed into varus. So under resecting the lateral compartments, something you have to take care of for your first cases. As I told you, we always measure what we resect. I use the base of the spine to measure the levels. Then we check what we've done. And here we resected 6 millimeters lateral, 7 millimeters medial. We have 7 degrees of slope and neutral aligned, so 0 degree of varus. That took 11 seconds. So the total Pixie helmet time, so that when you wear the helmet with the glasses and the camera, it's 8 minutes 32 seconds. And the distal and the proximal tibia cuts are performed in a controlled way. In this particular case, as you will see, I released a little bit the posterior capsule. The case now is tied medially, and there is some laxity lateral, and the patellofemoral joint is happy. That's the lady 1 day after surgery. She has active control of her leg. The leg is straight, and that patient is happy. I've done so far 700 cases, and we've published last year the accuracy of the augmented reality system. You can find it back in the Arthroplasty Today. And I can tell you, besides the tibial slope, because measuring tibial slope on conventional X-ray is not that easy, so there is some discrepancy there. But for the distal femoral and the proximal tibial angle and also the overall angle, we had very, very good values. My algorithm, when I started in 2021, was I used the CPAC classification, and for the types 1 and 4, so the varus types, I use the unrestricted kinematic align technique, 2 and 5, which are the neutral ones. You do the same. And for the valgus types, the 3 and 6, I used an adjusted mechanical align technique, like I just shown you. But that I did for all my cases. Nowadays, I'm gonna have some valgus left, but in a controlled way, as I will show you, for the cases that have non-contracted valgus, so reductible valgus. Here you see our data on the pre-op CPAC. So we have more than 30% of valgus cases. By using that technique between 2021 and 2023, majority of the valgus cases moved to the middle column. So we put them neutral, reducing the valgus cases to 7% instead of 31%. You see an example of a patient with a CPAC type 1. His pre-op move-up index is 43, and at 1 year, that score was doubled. It's a lot of varus on the tibial side. As you can see, it's more than 8 degrees, but that patient is not walking into varus. He's walking like he was, like his native knee. Here you see another example of a lady 2 months after her right valgus knee, corrected to neutral, pre-op index 51, index at 1 year 88. Varus and valgus knees, they are different. And here you see the aggregated data for a valgus and varus knees. They behave differently. That's why when you analyze them in a big cohort, you should make a distinction between both of them. Here you see our results between 2021 and 2022 for the different phenotypes. So CPAC 1 and 4 are the varus phenotypes, 2 and 5 the neutral ones, 3 and 6 are the valgus ones. Our move-up index on average was 70% increase for the varus types, 60% increase for the neutral types, and around between 55 and 60% for the valgus types. So it's really important to understand that different phenotypes, they have different outcomes and they have different starting values. And that's really important when you read the literature. Of course, we want to move further, and we started last year a comparative prospective randomized controlled trial comparing augmented reality to the Skywalk robotic system. We don't have the results yet because we want to publish the data at 1 to 2 years postoperatively. That's my alignment strategy nowadays. I go more to a functional alignment, especially in the correctable deformities. If it's a non-correctable deformity, like the case you saw, I will use a neutral alignment because I want to make my MCL tight, and you cannot leave an MCL stretched out in those cases. These are the data. So we kept them in valgus. Instead of 36% valgus, we went to 27% valgus. So the reduction towards neutral was less. We kept them in valgus. Will this influence in a positive way our outcomes? We're still analyzing this, so it's too early to make a judgment on that. Regarding surgical time, an issue that it's a lot of debate in the US, I think it's less in our hospital, is the mean time for a PIXI, augmented reality total knee arthroplasty. When we started with PIXI, our average time was 87 minutes. It's now down to 70 minutes, which is the full time the patient is in the operating room. So I think it's a very short timing. Our robotic cases, we are not that experienced yet with the robotic cases. It's 100 minutes for the first cases, but that will go down eventually as well. When you start with a new technique, I recommend you not to push, not to move fast. I think it's really important to take your time when you're starting using a new technique. Regarding the move-up index results, you see that the spread for the first PIXI cases was more than the last PIXI cases, and the same is true for the Knee Society satisfaction results. When I look to the forgotten joint score at a time point more than 1 year, because before that it's not easy to, it takes sometimes a year before patients are fully satisfied. When I started in 2012, the forgotten joint score was published in Switzerland in 2012. Our average forgotten joint score was 58 for mechanically aligned evolution medial pivot knee. For the sphere was 54. When I moved to unrestricted kinematic alignment, I had only 50. And that's because some of my patients ended up in valgus. And I tell you, residual valgus with the MCL which is stretched out, the patients don't like it. So that was done with just mechanical jigs. When I moved to the evolution, but then a more controlled kinematic alignment, I went to 60. Now with the PIXI, the system between 2021 and 2023, we went to 67. And for the newer technique, we went to 69. So we are improving constantly our results. I encourage you to measure your results as well, because that drives you into the good direction. Lisa, I think I've said the most important things. You want to do a Q&A as well, but I first want to end up with my messages.
Yes.
So a safe and consistent personalized medial pivot TKA for me needs technology, augmented reality, improve the accuracy and the clinical results. In our daily practice, we use a 1 millimeter and 1 degree threshold principles. Valgus needs behave differently, intraoperatively, preoperatively, and postoperatively. You can only improve if you're able to measure. So data are key. Thank you for your attention. I'm ready to answer your questions if you have so.
Okay, so I will take again the control and share my screen again, and then we can start with the different questions you may have. So we already have 2 questions in the chat right now. If you want to ask more questions, please feel free to go in the Q&A channel, and then we can answer to all your questions. So first question is for you, Dr. Van Overschelde. How many surgeries did it take you to feel comfortable using Knee+?
Well, it's easy. We've been measuring that with our outcomes, and depending on the surgeon, it's between 10 and 25 surgeries. For me, it was 10 surgeries, and my results stayed the same. But as I told you, for me, the most difficult to adapt was on the tibial side because of the large cutting block. There was some impingement on the patella tendon, and small movements of the cutting block can induce 2 or 3 degrees of error. So that's something you really have to pay attention. I think medical education, and PIXI is really involved in that as well. It is really important to get to know the technique.
Okay, thank you for this first answer. And then we have a second question. What do you like the most about augmented reality systems?
Well, you have immediate feedback when you do your cuts, and that's something I really appreciate. The system is very accurate, and the accuracy has improved over the years. The system was not that accurate when we did our first cases, but that's normal. It's in the meantime, it's 4 years. I can tell you the system is extremely accurate. I'm comparing now to our robotic system, and I'm really curious to see what the results will be.
Thank you so much for the second answer. So we don't have more questions right now. Oh, yes, we have. Thank you. So it's from Dimitros Dikos. Thank you very much for this excellent presentation. First, where exactly do you place the first sensor for the femoral cuts? Middle of the white side line.
Yes, I put it just in the middle, just above the notch. My first pin, which is a headed pin, is just a couple of millimeters above the notch in the middle of the distal femur. And I don't have experience with Nexstar. That's the next question.
Yes, thank you. I will just answer.
I think that's a medial pivot user. Do you always resect the PCL? Yes, I do always resect the PCL. For the simple reason is that it is very predictable when you do so. But you should take into account that resecting the PCL has an influence on your gaps. With the robotic system, we were able to check this. In extension, it's between 0.5 millimeter and 1 millimeter. In flexion, it's between 1 and 2 millimeters. And that reflects in the cuts we make. The thickness of the implant is 9 millimeters distally, and we only resect 8, measured 8. And on the tibia, we also resect 8 and the thickness is 10. So that accounts for that 1 millimeter that you gain by releasing the PCL. Why don't we conserve the PCL? Because it makes your technique or your results very reproducible. I know there are surgeons now who try to keep the PCL, but I know that in certain cases they will cut the PCL because the balance is not what they expected. So for me, being reproducible, it's cutting the PCL and achieving a very good flexion by doing that.
Okay, so we have more questions. Good, we have interest. So what are the boundaries for correction in varus and in valgus?
Well, as you've seen for the varus on the tibia, I showed you a case which had more than 8 degrees varus on the tibia, but the overall varus was only if I remember well, between 2 and 3 degrees of varus. So I think the overall alignment, I think, is really important. You cannot end up in 7 or 8 degrees overall varus. I will not do that. Same is true for the valgus. I started only in 2024 by keeping valgus for my knees that were in valgus preoperatively, because I saw my results by putting them to neutral alignment. And I think I'm doing a good job, but I will not exaggerate. So 2 to 3 degrees of valgus, if it's a native valgus knee with the very stable medial collateral ligament, is something I will do. But that's the overall alignment. You also have the combined alignment, lateral distal femoral angle, proximal medial tibial angle. Well, I have cases where I cut 5 degrees valgus on the femur and 5 degrees varus on the tibia. So overall, they will have a relatively neutral alignment. So I don't have fixed boundaries. It's case by case, but I will avoid to end up in let's say, more than 3 to 4 degrees of valgus in a native valgus knee, because my patients don't like a knee that is in too much valgus.
Thank you. Another question, do you see any impact on patient recovery using PIXI?
Say again, Lisa, which question is it?
If you see any impact on the patient recovery when you're using PIXI for surgeries?
Yeah, so as you have seen, we collect our data, and I only showed you the results at 1 year because I think the recovery is multifactorial. It's not only the PIXI system or another technology, but balancing your knee in a good way helps for the early post-operative rehabilitation, besides the multimodal pain management and all the other relevant things that you should implement in your practice. Typically, our patients, they go home the next day. Some patients want to stay 2 days. It's up to them. When they feel comfortable, they go home. Is it only PIXI that allowed me to send patients home even the same day or the next day? I'm not convinced it's that. It's the combination of many things together that makes that the patient is very comfortable after surgery.
Thank you. And we have one last one. It's testimony. I've done a few Sorbonne tests with the PIXI, but had difficulty with the headset and seeing all the probes. Do you have any practical tips on setting up the headset?
I don't have issues with the headset. It's always an adaptation, and for me, it's typically 10 cases. We moved from just the glasses without headsets now to a headset. There is always some adaptation, but I must say it's very quick. I very often have a case where I forgot to remove the headset when I've done the cuts, and my nurses tell me, you still have the headset on. So by doing more and more cases, I think you don't even feel the headset anymore when you're operating.
Thank you very much for those answers. So we don't have any open questions anymore. We still have a bit of time, so if you have any questions for all the participants, feel free. Otherwise, we will conclude with this session. Just gonna wait 1 minute or two. Okay, so I don't think we have any more questions. So let's conclude this webinar. So thank you so much for all the participants. It was great to have you here today. I hope you can learn from Dr. Van Overschelde. If you have any question, you can still contact us at the email address, and we will also send you an email for all the participants at the end. We're gonna be next week at the effort in Lyon. So if you're gonna be there, feel free to join us at the booth. We can do demonstration with you, and we can also talk. So it's gonna be from the June 11th to 13th in Lyon Convention Center at the booth B12. So please come and meet us. And then Dr. Van Overschelde conclude with his parts.
Thank you very much, Lisa. I hope we could entertain our audience. And if you want to contact me, please feel free. My email address is info@vioclinic.com. I'm more than happy to answer remaining questions. And thank you so much.
Thank you so much. Goodbye. Have a good evening.
Bye-bye, Lisa.